We're going to start our Q&A. We've got some really good questions already. So we're going to key up our first one. Kira, go for it.
So, Dr. Sanani, Jason asks, are there ways to see if the Bipap settings need to be adjusted without having a sleep study due to COVID and trying to limit exposure to hospital-like settings?
Yeah, this is obviously a real concern. The short answer is no, there's no easy way to know whether settings are appropriate or not, short of a sleep study. I want to kind of bolster this answer with a few other comments. One is that if the sleep study has taken place within a couple of years, there's probably no immediate urgency unless there's a change in the clinical condition or their new symptoms. In which case, yes, a sleep study would be better to re-titrate or readjust pressure settings if needed. In the current environment, a lot depends on what the safety protocols are at the local institute. There are many labs in the country right now that will not take anybody in without a negative COVID test, especially for pressure titrations. So if you know that that is a policy and a protocol, then obviously you're in a much better place to get the test done. I kind of like to say that, the best time to really get a test is when people's anxiety levels are high and the thresholds to test people are very low. Some parts of the country, there is certainly greater degree of anxiety, both in care providers as well as the community. And so there's reluctance to bring people to the lab as well as for people to want to go to the sleep study. And in other parts of the country, unfortunately, there's a little more cavalier attitude. So a lot depends on where you are and what your immediate environment looks like and what the urgency seems. If there needs to be a change, we can always test a couple of empiric changes before really committing to suggesting the need for a more official titration. But we've made changes on the fly for some of our patients and not committed everybody to a routine non-sleep study, if I may, every so often. I don't know if anyone else had some other thoughts or comments.
I mean, the only other thing that you could potentially use, and I agree with Command, I mean, the sleep study is the best test for many reasons. But sometimes the new devices, they record some data. They are not as good as what you will see on the sleep lab, but they might give you some surrogate data of maybe you might need to tweak one of the pressures. I mean, you might increase the difference between the inspiratory and kind of like that expiratory holding pressure, the EPAP and the IPAP. But it's hard when you have an obstruction. That's when you really, really need that sleep lab. But maybe using technology and, again, worst case scenario, you can even use a transcutaneous CO2 monitor maybe at home. But that will be if the sleep lab is closed and there are some potential issues that you cannot come into the hospital. That is not that urgent.
I think that's
Our
a really
adult
good
colleagues
point.
have done this quite commonly, and they actually have transcutaneous CO2 monitors that can be sent out to the home that can record capnography, which is carbon dioxide, which is the value that you need to follow to make sure that you're correcting for respiratory failure. They have a model for doing this that we haven't adopted yet. And so I think I would agree with what Drs. Perez and Soani said, that still a sleep study is the best way to do things. And as we go further into the COVID pandemic and managing things, we may need to look at different ways of titrating and adjusting settings.
Yeah, I think the point of a download, as Dr. Perez mentioned, is really key. We pretty much would always start with that. If there's more leak, that's an easy fix. You don't need to go to a sleep lab for that. And that can certainly resolve symptoms. So certainly starting with the download and then escalating as needed is perhaps the best way to go.
Great, thank you. Sophie?
All right, so Dr. Boo, Melissa asks, is there an age limit for improving lung function?
So my answer would be no, there is no age limit in terms of, and I wasn't sure of the age limit in terms of being young versus old, because it can go either direction. I think the thing about CMD that was talked about is that there are a lot of different types of CMD, and there are different trajectories to lung function, but everyone breathes from the time you're born to the time you until the end, right? And so there is always opportunity to work on breathing. I think that you know, when a person can't have measurement of their lung function yet, then it's still the same philosophies of working on chest wall muscle strength, chest wall flexibility, which is done through physical therapy, through different assistive breathing devices, whether it be the assistive cough device, other known as a cough assist, or even with the different ventilators with positive airway pressure can help with lung recruitment and chest wall flexibility. And also nutrition is really important as well for lung health in the long term. And so I think that partnering with your neuromuscular center is really important, with a physical therapist that's there, your neurologist, and having a pulmonologist as well from the time of diagnosis, and having regular follow-up with time.
Anybody else have something to add? Excellent.
I'll just add that because, you know, with congenital muscular dystrophies or myopathies, you're losing muscle, it's hard to regain function if it's lost. So the focus is really preserving what you have. And that is the focus of starting both respiratory support with Bipap, starting the cough assist, and starting exercises to help with maintaining flexibility of the rib cage and making the muscles work as smoothly as possible. And all neuromuscular foundations and parent support groups have really advocated for taking proactive steps to address respiratory dysfunction. And Rachel certainly pushed this quite a bit, and as has Cure CMD, and the perfect evidence is this entire platform. So being aggressive and engaging with pulmonologists and respiratory therapists is absolutely critical in preserving function.
Great.
Question? All right, so Dr. Perez, Simon and Hannah say, I use my cough assist on a daily basis. I was never given specific settings for the cough assist, so I am unsure as to the ideal settings that I should be using for my cough assist. What advice would you give to have my cough assist settings that are optimized to the user?
That's a very good question, and it's not straightforward. I think that every patient needs different settings. There have been some studies of what pressures you might need usually in older patients, like teenagers and adults. What would be the ideal pressure? I think that the bottom line is to work with your pulmonologist and your respiratory therapists when you're using your cough assist. The goal is to reach out the pressure that it will allow you to expand your lungs. Remember that Dr. Meyer was telling you that they run this study trying to do this hyperinflation. That's the first phase of coughing, right? You inflate your lungs all the way as much as you can, and you try to generate a negative pressure to get the mucus out. So again, for perhaps older patients, pressures between 40 to 45, I'm not talking about older, like probably 10 years of age or so, maybe younger. But at the bottom line is that you need to see what pressure would elicit that expansion in your chest wall, and it will allow you to get the mucus out. There are certain indications, again, using the cough assist twice daily, once maybe in the morning, once in the afternoon. Is important to always finish with kind of like a positive pressure. You remember your lungs are kind of like a balloon. You don't want to end up with the lungs kind of like a squish. You want to end up with an expansion. And then again, it depends. When you're sick, you're going to use it as needed, as often as you will need it. There are different cycles that are different parameters, but working with your pulmonologist and your respiratory therapist will be the best way to go. Anybody else maybe has some thoughts?
Yeah, I would add that if you don't really see much chest movement, or you don't experience a very full breath and a little more than just that with the use of the cough assist, then perhaps the pressure or the time could be adjusted a little bit more to provide that sense of stretch.
Yeah, I'll add that the best way to find the right cough assist settings is to try. And most important is the inspiratory time. So allowing yourself the time to expand the chest, and then and the pressure is both inspiratory and expiratory. And that takes an experienced respiratory therapist or pulmonologist and a patient who can give feedback. So it's really about bringing your cough assist to the clinic and trying new things, trying new settings, and sometimes even thinking out of the box. Most of our patients probably have cough assist settings that are the same inspiratory pressure and expiratory pressure. That doesn't have to be the case. It's whatever works for you, and you just have to try and find what works. And sometimes when you're sick, something else works. Different pressures, different times work. And so you have to be flexible.
Are we ready for a new question? All right, so Dr. Meyer, Nikki asks, what is the difference between Bipap and Trilogy?
BiPAP is bilevel positive airway pressure. It's a therapy. The Trilogy is a device produced by a company to provide BiPAP. There are a few other devices that are on the market, but the Trilogy is just simply one of a number of different devices that can effectively deliver BiPAP. It's quite commonly used in patients with neuromuscular disease because it's quite sensitive to sensing when the patient's trying to breathe. But it's just simply one of the devices that can be used. The trade name, essentially. It's like Motrin for ibuprofen.
Kira?
Sorry, I had to check something. I got a notification on Slack. So, Dr. Kupfer, Nikki also asks whether pulse ox is the best indicator of letting us know if you're retaining carbon dioxide. So, if pulse ox is 96 or 98, but you have a bad headache, could it be from CO2 retention?
So the short answer is yes, it could be CO2 retention. Oxygen levels don't always tell the whole story. You don't always know what your CO2 is if your oxygen is normal. It's maybe more likely that your CO2 is okay if your oxygen level is normal, but it's not always the case. So no, you really need a full blood gas to check the CO2 level to make sure that your symptoms are not related to hypoventilation.
Okay, we have another question. Magdalena asks, what do I need to know when I take my daughter to the ICU with breathing difficulties when she has a respiratory infection? And she is typically given oxygen and doesn't have any breathing aids that she uses on an everyday basis. Dr. Sonani, do you want to take this?
Typically, I mean, the question suggests that this has happened more than once, which is concerning. We don't typically administer just exclusive supplemental oxygen to our patients who have neuromuscular chest wall muscle weakness. And it does not address the issue of elevations of carbon dioxide that may be occurring in the background. The problem with any fever, let alone pneumonia, congestion, is that you tend to produce your burning temperature, calories at a higher temperature, you're producing more carbon dioxide. And so ventilatory support, either with BiPAP or any other device, is critical. What also concerns me is that if this is what's happening in an ICU setting, then perhaps some baseline pulmonary management also needs to be tweaked. It isn't often that we have recurrent pneumonias in our neuromuscular patients in this day and age when they're closely followed and monitored. So certainly having some additional support, the regular use of cough assist, nighttime support, all those should be in play. If your child is currently on nighttime support, there's perhaps some benefit to extending that support into the day as well, particularly when they are sick. So I think ICU managements in neuromuscular disease are an interesting topic, but they require really good conversations between parents, providers, and ICU staff so that the expectations are very clear and transparent. I don't know if anybody
The
else
only,
has.
the only thing that I would like to add is, and again, it's hard to follow completely the question, but if a patient with a neuromuscular disorder is admitted to the ICU and is placed just on oxygen, I would suggest to consider using either a bi-level positive pressure machine like a Bipap. Remember that on your first episode, we talked that the lungs are actually normal. It's a muscle issue. And when you're sick and you have a fever, you get weaker. Anybody that gets a cold or a flu, you get weaker. So what we will need is actually a machine that will help you to expand your chest wall, to help you to breathe a little bit better. And that might also help with the oxygen. So providing just pure oxygen with nothing else is usually something that we will not recommend. If you need the Bipap on top of that oxygen, then it's fine until your lungs tend to recover. But ideally, we should start a device like a Bipap when they go into the ICU, along with the cough assist and any other therapies to try to clear the mucus from the lungs.
I want to emphasize what Dr. Perez just said, that the first and clearly most important thing is to start somebody who has low oxygen and has a neuromuscular disease on some type of ventilatory support. And then the second, third, fourth, and fifth thing is all the cough assist. In other words, aggressive cough assist is absolutely critical. Ventilation will stabilize the patient, but the patient's not going to get better unless they have an adequate way of clearing their airways. And in my experience, that's the single most commonly missed treatment in facilities that aren't familiar with taking care of patients with neuromuscular disease. And if there's one thing that you can do if you have a cough assist and your child is sick and goes to the hospital, is bring it just in case the hospital doesn't have one. That will help to shorten the duration of an illness and help to get you or your child out of the hospital much faster. One of the things that's often lost in many pulmonologists or intensivists that aren't familiar with neuromuscular disease is expecting that using an antibiotic will help to take care of a pneumonia. And that works for those of us that can cough effectively. But if you can't cough effectively, you're not going to get well as quickly as you should without having adequate airway clearance with the cough assist.
I'd just like to add that don't forget your team. So if you're going to the ER, if you're going to the hospital, call your neuromuscular team, call your neurologist, call your pulmonologist. We'll help advocate for you to get the right therapy. Even if you're not going to our hospital, we can easily pick up the phone and call people, and we're happy to do so.
Next question.
Yep.
So, Dr. Boo, Teresa asks, is cough assist the best method to help maintain the muscles and the ribs' ability to expand?
Yeah, so the goal for patients to be proactive and to keep your lungs working well and your breathing going well is to maintain respiratory muscle strength. And so the cough assist is just one method, right? So the goal is to have deep breathing and expand your chest wall, which can be done with breathing exercises if the person has the strength to do it, or to use assistive devices. So a low-tech device would be something called a bag with a mask that is like a resuscitation bag of the mask, but it does need to have a one-way valve. That for me in California has been hard to find to buy commercially. I do believe it's available in Canada, but and maybe if there are any international participants, it may be easier to find. But in California, I haven't been able to find it. So one of the most common devices I use is the assisted cough device, and I use the Cough Assist. And with this device, I'm able to force air in with causing that chest expansion and chest stretch, and then forcibly exhaling the patient if necessary. So from Dr. Soanani's work and Dr. Mayer's work about assisted cough with lung volume improvement and breath stacking, has been shown that using the cough assist can potentially slow down the decline of lung function over time. And then in addition, another device that can be used to help promote chest wall stretch and is with any positive airway pressure device. So your Bipap device, and as Dr. Mayer said, there's a lot of different commercial devices available on the market. And so it's something you can work with your pulmonologist or your respiratory therapist or your physical therapist to go over the different techniques.
Next question. Okay, so Dr. Pasco, Daniela asks, is it beneficial to use a cough assist daily when you only got the machine for the first time at age 50? And she's heard that it's too late to really stretch out the chest wall, and it's only beneficial when you start at a younger age. Is that true?
Sorry, I'm sort of hoping I'm not making anybody sick to their stomach as I move. I'm currently on service, and then there's some conversations behind me, so hopefully you can hear me okay. That's a good question, and I think part of it, first I would say it certainly couldn't hurt. Part of it depends, I think, on the shape of your chest wall and if there's any sort of significant scoliosis that could be contributing as well to limited movement. But if it's more, if you've had sort of gradual progression and the chest wall, in other words, if your weakness isn't really significant at this point, then it might actually be something that could help. But even if your chest wall doesn't move a lot with it, it's definitely not going to hurt. Plus, it's also good to know how to use the machine very efficiently and with proper techniques. So that way, should you need it for an infection down the road, then you'll be accustomed to it and accustomed to the pressure and everything like that. So I hope that answers your question. It's sort of a little bit of a, I think it sort of depends on how long things have been set in place, but it's a great question. And I would open it up to anybody else if they have other more direct input there.
I think what I would just add is that the benefits should not be considered limited only to preserving lung function or so, but it's also really to help maintain good quality of airway clearance.
I should add too, the cough assist really truly can keep you out of the hospital.
Next question. So actually, Dr. Meyer, Hannah asks, is there a particular age at which one should start Bipap?
No. The question is, when do you start needing Bipap, which really means when do you have respiratory failure? The only way that you can really determine that is by doing a sleep study or doing some other measurement of carbon dioxide. And so in many situations, what the recommendation will be is at a certain point to do an annual sleep study or to ask a series of questions that may indicate difficulty with sleep at night. It's very non-specific, but it can sometimes clue you in to when you actually need to get a sleep study. So there's not a specific age. It's really a matter of having determined that a patient may be at risk and then getting a sleep study. I think there's a fine balance between overdoing it and getting a sleep study every single year from the time of diagnosis and then waiting until there are clear symptoms. the sweet spot is somewhere in the middle. And the typical approach that I take is if I have any concern at all, even remote concern about a patient potentially changing and having respiratory difficulty at night, to get a sleep study. So the only way you know is by just getting a sleep study. And may not be a real satisfactory answer, but there's not a specific age that after which people need to get a sleep study.
Yeah, I'd like to echo that too, in terms of there are multiple things that for all of us on the panel that look at to decide if a patient has insufficient breathing. So it'd be the symptoms of breathing, but also some symptoms that you may not even realize is associated with breathing, such as growing, gaining weight, headaches, we've already mentioned it, nausea. Change in functionality is another clue on when the patient may have changes in their breathing adequacy, and then lung function testing is one thing we haven't mentioned yet. And so there's a question late in here about when are the next episodes coming. So there's gonna be a whole, I think, segment on lung function testing. And then the sleep study will ultimately give your diagnosis. There are some conditions though where we as providers know the natural progression of the disease and can expect when a patient may need assisted breathing, just based on our experience as well.
All right, Dr. Kupfer, Avery asks, do you have any suggestions for a BiPAP mask for teens? And she finds that hers is starting to leak a lot when she's lying down, and she's just wondering if she should change the type of mask that she's using.
So finding the right mask is like shopping for shoes. It takes a lot of searching to find exactly what's right. And then when you think you did, you didn't. So really it's about trying different masks, making sure that they're not too tight. That's often a mistake that people make. Most of the modern masks are made to inflate with airflow. And so if you squish them on the face too much, they're not going to inflate and they're not going to create their own seal. So making sure that they're fitted right, and then that the mask itself and the interface fits you is really important. That's such an individual kind of thing that you really have to be involved with a sleep lab or a pulmonary clinic that has a fair number of options. There are different types, some that fit only over the nose, some that are gel fitted, more are now, like I said, air pressure fitted, which is probably better for the skin. Some are intranasal devices or nasal pillow type devices, and then there are new ones that are more of kind of an under the nose basket, or I don't have a better term than a nasal trough. That's probably a bad way to think of it. But there are all these systems that really are made to fit different shapes and sizes of noses and nostrils. And the most important thing is trying them out. Sometimes the DME company where you live may be able to do a mask fitting for you as well. It just depends on what the resources in your area are. So it's really a trial and error, and it can be extraordinarily frustrating. The one thing that I remind people is that I really do not like masks that fit over the mouth because airflow, we're supposed to breathe through our nose, first of all, so I'd like to use that part of our anatomy for breathing. Two, if we cover the mouth during sleep, it's hard for people to communicate. And if your BiPAP causes you nausea or you are otherwise sick and get nauseated and have to vomit, there's not an easy way to get the mask off in time, and it may actually cause more issues like aspiration. So I really prefer to stick to nasal only devices. I'd love to hear what others have to say too.
Next
Can't
question.
disagree.
Oh.
Can't disagree with you. Have nothing.
Likewise, if the shoe fits.
Or you need to buy shoes at different places.
Kira?
Okay, actually, Dr. Sinani, Holly asks, how often should our children be receiving a sleep study to check for apnea?
So I'll break this down into two parts. One is the simple answer is the first study is really with index of suspicion, and I generally tell people that it's to be done at the time of understanding the diagnosis. And more so the clinical evaluation. If I see somebody in clinic where the diagnosis is still unknown, but the chest does not move much while awake, that person's paying a visit to the sleep lab, because if that's not happening while awake, then it's not likely to happen much while asleep. The second part is that the only issue that we see, in fact, I would say sleep apnea is perhaps the least common issue I would worry about with congenital muscular dystrophy. And because these children are seldom highly overweight or obese, they are unlikely to have obstructive sleep apnea. But they're more likely to have elevations in carbon dioxide level, which is what I worry about more for them. The elevations in carbon dioxide level can occur even in the presence of, maintenance of ambulation. So unlike Duchenne muscular dystrophy, where they will typically lose the ability to walk before they have to deal with sleep-related breathing issues, the reverse is true for many forms of congenital muscular dystrophy. So index of suspicion should be high at the time of diagnosis. And I say we at least start with a baseline sleep study whenever the diagnosis is made, and then we can determine subsequent studies based on growth, symptoms, and need. Generally, I would say it's about every 12 to 18 to maybe 24 months tops. But once a diagnosis has been made or once the need for non-invasive ventilation has been established, then rechecking pressures is really kind of every 2 to 3 years, maybe a little later, longer, if nothing else is changing. So hope that answers the question.
If I can just jump in, I'm one of the non-sleep trained people, and I'm going to render an opinion on sleep medicine. And that is that one of the challenges in interpreting a sleep study that you need to be aware of is that many of the criteria used for determining whether somebody has respiratory failure or has obstructive sleep apnea, there's quite a bit of overlap. And so sometimes we get reports back on our patients with neuromuscular disease who have no evidence at all of obstruction, no snoring, no obesity, no large tonsils. And the sleep study says obstructive sleep apnea. And it's important to dig a little deeper and look at the carbon dioxide value, because sometimes during sleep, in this type of a study, you can see carbon dioxide values that are trending on the high side. And so if your pulmonologist informs you that your child has obstructive sleep apnea, I would recommend in a diplomatic way to say something to the effect of, "Are you sure?" And then open up a discussion, because unfortunately sometimes the sleep study can be misinterpreted, or the data can be misinterpreted, but in compliance with the way that the guidance is given. And so new guidance is soon to come on how to try and bridge this gap.
I think those are all absolutely. I'm so glad you mentioned that. That one thing that we do tell our patients if they're going to get a study locally is make sure that they ask, is carbon dioxide level monitoring a part of the study? There are many adult-oriented sleep labs that don't measure carbon dioxide levels during sleep. And that's the one ask I say you should have of the lab. Otherwise, the study should not be done or wasted in that environment. And yes, the interpretation of the study needs to be in the context of the diagnosis. There are many subtle indicators. Yeah.
I think that's a very key statement. Can you repeat that one more time about?
Yeah, that the study should be interpreted in the context of the diagnosis. There are many subtle indications that come up in the sleep study. And there's a group effort amongst us over here to describe that in the literature further. Because there are certain compensatory mechanisms that take place before the carbon dioxide level goes up. So someone's breathing a little faster because they can't breathe deeper. To me, that, and still maintaining a normal carbon dioxide level, that's also an abnormality that needs to be recognized and if not, at least trended. And many labs will not even look at the breathing rate, even though it's a sleep study. So two things are important: how fast you breathe and carbon dioxide levels. These two need to be monitored and described in the report.
And just to add to, I think the dream sleep is sort of a challenge state for us as well when we lose our muscle tone, except for the diaphragm, essentially. And rapid eye movements, so your eyes sort of twitch around too. But that is a time point where it's really helpful. That's where hypoventilation or the sort of respiratory failure may really manifest. And so it's helpful when we read a sleep study, knowing the diagnosis, to sort of pay attention, especially to dream sleep, and see how things look there. And even among some pediatric sleep labs or within a lab, depends on the interpreting physician, respiratory rate's not always commented on. And so that is something, that's an ask that's really, really, if we got everything we want from the sleep perspective, the end-tidal carbon dioxide, especially during dream sleep, and the respiratory rate are very, very helpful. And I believe, I'm sorry, I wasn't able to be on earlier, but I'm pretty confident that we discussed those aspects during the sleep portion of the amazing interviews that we had. So.
More information to come.
Okay, so Dr. Meyer, Onur, and I hope I pronounced that correctly, asked, my daughter is 5 years old and doesn't have any breathing problems currently, and she has ORIC, just for context. Is it still recommended to use cough assist to practice in advance?
I would say the simple answer is yes. One of the things that we do very well is telling you how well your child's doing when they're well. What we can't do is predict how they'll be when they're sick. And so the approach that we all like to take is to make sure that you're forearmed and forewarned, and have the capacity to start cough assist or start airway clearance as soon as there's that first respiratory illness. Having said that, some payers in some parts of the country are fairly restrictive in allowing more proactive introduction of the cough assist. And we're fortunate in the greater Philadelphia area to not have that problem. And so our approach has typically been to try and introduce the cough assist into regular care fairly early in disease, so that if it's needed during an illness, that it's there, and that illness may be able to be effectively managed at home as opposed to progressing to the point of requiring hospitalization.
All right. So, Dr. Pascoe, Christina asks, could deformation of the thorax be corrected by Bipap use at night? And does wearing a spine brace impact breathing function?
Right. So maybe and yes, I would say. And what we suspect is that, and I think it depends on the age of the child or the patient in terms of how skeletally mature they are. And in other words, the younger you are, then the bones may not be quite as ossified. You have more cartilage, maybe more deformable or reformable chest. But it also depends on the BiPAP settings you have, and if the if you're able to really truly relax and let the BiPAP machine breathe for you at night, you won't be using your muscles quite as much. And what we think is that when you're using your muscles more, if you have a weaker chest wall and your diaphragm pulls down, then it could cause the chest to maybe pull in a little bit more, and that could contribute perhaps to like a pectus deformity, if you've heard that term. And so if you're able to really give good pressure, let a patient relax, we have seen just sort of anecdotally that we can sort of alter the shape of the chest wall in more younger patients. But I wouldn't say it's a complete guarantee. Your question about the bracing is absolutely it can, because it'll affect the mobility of your ribs and potentially how big of a breath you can get, things like that. That's not to say you shouldn't use it. Absolutely you should, but that could actually be a consideration for, if your child has a brace at nighttime, they're sleeping, they're going to have a brace for a while. It may actually be worth having a sleep study potentially with the brace on and trying to figure out, does it induce respiratory failure, or how significantly could it alter pressures that might be needed? So just sort of food for thought.
Okay, so I think we have our last question for this Q&A. Again, thank you all so much for your amazing questions. If your question didn't get answered, you can email the team at breathe@curecmd.org, and they'll do their best to provide some guidance. So our last question is Dr. Boo. Melissa asks, will CO2 levels be higher during the day if they're high at night?
Yeah, so the easy answer is actually maybe. So classically in respiratory insufficiency or inadequate breathing, the thought is that it first shows up while you're asleep, and then a person can compensate during the day. So a person can have high CO2 at nighttime, and then by the time they wake up, or in the first half hour after waking up, they end up normalizing. So the daytime CO2 will become normal. And then as respiratory muscle weakness progresses, then you get daytime high CO2s as well. So that answered that question. I don't know if anyone else has any other comments.
Okay. Well, thank you everyone so much. We really, really appreciate your time today. Just to answer live a question that was asked on the chat about future episodes. So we have 8 total episodes. We're planning on each of them being about 15-ish minutes. And we will be releasing them through the winter, and each chapter or each webisode follows the chapters in the CMD pulmonary guide at curecmd.org/breathing. So it's the next one is pulmonary function testing, like Dr. Boo said. Then episode 4 is sleep studies, 5 is ventilation, 6 is airway clearance, 7 is acute care, and then 8 is sort of a wrap up and about what was learned and about self-advocacy. So thank you, everyone. We just had such a blast working with you over the last few months and doing these and making them. So thank you again. Any questions can be forwarded to breathe@curecmd.org, and enjoy. Hopefully everyone gets to enjoy a little break at the end of the year. Hopefully. I know the doctors probably don't get much of a break, but we really appreciate you, and thank you again. Happy holidays. Happy New Year.
Happy holidays.
Happy
everyone.
holidays.
Happy holidays, everyone. Thank you so much.
Happy holidays. Thank you.
Take care.